Welcome, everyone. My name is Rachel Massey, and I'm the Senior Science and Policy Advisor with CHE, the Collaborative for Health and Environment. We're really glad that you're all able to join us today. We invite you to put a note in the chat introducing yourself and where you're joining in from if you'd like to. I'm just going to start with a few bits of housekeeping. CHE is a member group of the EDC Strategies Partnership, which is bringing you today's webinar. The partnership members include Healthy Environment and Endocrine Disruptor Strategies, or HEEDS, a program of environmental health sciences, the Biomonitoring Resource Center, and the Health and Environment Alliance, or HEAL. CHE also hosts science discussion listservs and supports other collaborative programs focused on promoting environmental health and justice. If you're joining us by phone, you can download the slides from the webinar page on our website at healthandenvironment.org. For those who are online, we'll put that link in the chat now. We will disable the chat during the presentations, but please do type your questions in the Q&A box at any point, and we'll get to as many comments and questions as we can after the presentations. If you'd like to activate closed captions, you can do that by clicking the button on the bottom of your screen. This webinar is being recorded, and it's scheduled to last for half an hour. With that, I will hand it over to today's moderator, Charles Patton, Director of the Biomonitoring Resource Center. Charles?
Thank you very much, Rachel, for opening up this webinar. And good morning, everyone. So glad you joined us. Today's webinar digs into a remarkable, groundbreaking study. In this study, non-targeted analysis methods were used to identify chemicals that are not regularly studied and sometimes have never been studied in pregnant women's samples and in cord blood. The researchers were then able to quantify these chemicals and associate them with adverse pregnancy outcomes. This research was carried out by Dr. Jessica Trowbridge. She's an associate researcher with a program on reproductive health and environment, or PRE, at the University of California, San Francisco. Her curiosity about the impact of exposure to environmental chemicals on health came out of her experience living binationally and experiencing the environmental burdens of pollution in her communities in central Mexico and in Richmond, California. She's extensively studied exposures to toxic environmental chemicals in women firefighters and pregnant women in order to inform actions and regulations that may ensure safe and healthy pregnancies and toxic-free babies. Dr. Tracy Woodruff is the Allison S. Carlson Endowed Professor for PRE and is a professor in the UCSF Department of Obstetrics, Gynecology, and Reproductive Sciences and the Philip R. Lee Institute for Health Policy Studies. She's also the director of the newly awarded NIHS Environmental Health Core Center grant, the Environmental Research and Translation for Health, otherwise known as EARTH, the center at UCSF. She's a recognized expert on environmental pollution exposures and impacts on health with a focus on pregnancy, infancy, and childhood, author of numerous publications, and she continues to be a pioneer in the exploration of the interface between health and environment. Okay, Jessica, I'm going to turn this now over to you.
Thank you so much, Charles. Thanks for having us today. I'm really excited about the opportunity to share the results from our study that was published in EHP in 2023, just this past July. Today, I'll first start by presenting on the breadth of exposure of the problem on exposure to environmental chemicals. I'll talk about the relationship between exposure and health outcomes broadly, and then I'll talk about what we did and share the results from our study. I aim to use the term birthing people throughout my talk to be inclusive of the fact that all gender identities, including trans and gender non-binary folks, experience pregnancy and delivery. We have nothing to declare. So first, to set up the landscape of this presentation, I want to start with some background. And as Linda Birnbaum, former director of NIHS, has said, we live in a chemical soup. We are exposed to multiple toxic chemicals in our environment, from our homes, our work, our communities, our food, our beauty products. Chemicals are everywhere. And at PRE, our focus has been understanding the extent of exposure and the impact of those exposures during pregnancy. So previous studies from the Program on Reproductive Health and the Environment have found that pregnant women are exposed to at least 43 different toxic environmental chemicals. And it's important to note that these are chemicals that we know something about. These are ones that we've looked for and measured. And so we know that babies are born already exposed to toxic chemicals. Chemical exposure is a global problem. Exposure is ubiquitous. We have multiple exposures from things in our homes, as I said. In the US, there's about 40,000 chemicals that are actively used under the Toxic Substances Control Act. About 8,000 of them are considered high production volume chemicals. These are chemicals produced in over 1 million pounds per year. This quantity of chemicals equates to a number that I can barely wrap my head around, which is 9.5 trillion pounds of chemicals per person per year are used in the US. That's about 30,000 chemicals, 30,000 pounds per person per year. Of this, we know very little about the number of chemicals that we're exposed to. About 350 are regularly biomonitored in large biomonitoring studies, such as the National Health and Nutrition Examination Survey. And even fewer still are evaluated for their impacts, for their health impacts among pregnant women and children, pregnant people and children. We know that chemical production is inextricably linked to fossil fuel production. We've seen increases in the production and consumption of fossil fuels, particularly in the last 50 years. And as the levels of as the production has gone up, so have the number of chemicals that we continue to use in our environment. As chemical production use increases, so have the resulting health consequences become more common. We know that exposure to toxic chemicals like endocrine disruptors can occur throughout the life course and developmental stages and can have different effects depending on when those exposures occur. And exposures during pregnancy can result in things like low birth weight, birth defects, infant mortality, childhood diseases, and also cancer and asthma. These adverse health outcomes are increasing over time. So we've seen increases in the rates of neurological disorders in the past 30 years. These data are from 1990 to 2019. And so we've seen increased rates from neurological disorders, chronic respiratory disease, and diabetes. The exposures that occur during pregnancy can also have impacts on the mother. There's important biological changes that occur during pregnancy that can make pregnant people uniquely vulnerable to these adverse health effects. And the changes that occur during this time and the adverse health outcomes that occur during this time can have important consequences for both the fetus and the mother. We've seen increases in the rates of pregnancy-related complications. So gestational diabetes has increased 30% in the last decade. And we've also seen increases in pregnancy-related hypertension and preeclampsia. Preeclampsia is defined by having protein in the urine as well as high blood pressure. It is a major cause of maternal and fetal mortality worldwide. And both mild and severe cases of this can have lifelong consequences and can impact the heart and other organs. Like as I mentioned, pregnancy-related complications can have lifelong consequences for the birthing parent and the infant. Women who have preeclampsia during pregnancy have a higher risk for cardiovascular disease later in life. Gestational diabetes, women who have gestational diabetes have an increased risk for type 2 diabetes also. And so while maternal deaths have decreased worldwide, the rates have increased in the US, and the US has one of the highest maternal death rates of any industrialized nation, begging the question, what is the link between environmental chemical exposure and pregnancy complications? The overall goal of the grant that this study was performed under was to discover novel environmental chemicals in a diverse population of maternal infant pairs, applying non-targeted techniques to discover novel chemicals. And the results that I present a little bit later build on previous analyses on this cohort. In 2021, my colleague, Dimitri Abramson, he's now a professor at NYU, applied a computational pipeline to identify novel chemicals in pregnant people. He used non-targeted analysis to identify chemicals in about 300 matched maternal and cord samples, and confirmed 8 chemicals to analytical standards. So then the goal of this paper was to quantify those novel chemicals identified previously using Dimitri's work to be able to compare the levels between maternal and fetal samples and evaluate the association between chemicals and the adverse pregnancy outcomes. So I mentioned that Dimitri's paper used a non-targeted workflow. So to understand non-targeted analysis, let me first explain what targeted analysis is. In targeted analysis, you know what you're looking for. So let's say you want to know how much PCBs or polychlorinated biphenyls is in a person's blood. So you purchase an analytical standard and you measure PCBs, comparing what you measure in people's blood to that analytical standard. So you know what you're looking for. You can also do non-targeted analysis where you aren't informed by what you know about the chemical exposures. You can use a suspect screen where you search for a set of chemicals, but you are letting the data speak for itself. So you do a scan and see how many of them match what you're actually looking for. Or you can search for all detectable masses using analytical chemistry methods. So for NTA, we use high resolution mass spectrometry to identify peaks. You apply an iterative and computational workflow to assign tentative analysis to those peaks. We call this features because we don't know exactly what they are. We can apply an electrical charge to the samples to break apart compounds. And since compounds break apart in predictable ways, this provides further information that will allow us to further identify those chemicals. We call this fragmentation. And when we have an educated guess on what's in our samples, we then can purchase the standards from a company and compare the peaks that we got through the HRMS to the peaks from the known chemical standard. And that's how we confirm those chemicals. One limitation of non-targeted analysis is that you have a peak, but not a concentration. So since you're looking at peaks within the HRMS, you can't compare the peaks between different chemicals. And you also can't really evaluate the relationship with adverse health outcomes because you don't have a concentration for each individual. So in this paper, we took the findings from these previous studies, we took the chemicals that were identified and confirmed in prior steps, and then actually measured the concentration in each of the maternal and cord blood samples. We selected chemicals for quantification if first they were identified in those prior non-targeted studies. We also selected them if they were high production volume chemicals, again, produced in over 1 million pounds per year, or if they hadn't been tested previously in pregnant people. So for this study, we selected 9 chemicals for confirmation and quantification. They included perfluoroalkyl substances, fatty acids, and several solvents. The solvents I'm not showing here because they were detected in less than 40% of our study participants, so we didn't include them in further statistical analysis. So I'm focusing on the ones that we actually went through and evaluated for their adverse health outcomes. So for PFAS, these are high production volume chemicals produced in over 1 million pounds per year. We looked for linear and branched forms of PFAS and PFHXS. These chemicals are used for their stain, water, and grease resistant. So they're also in our paper takeout food containers, ergo the pizza boxes. They are in our couches and fabrics because of their stain and water and stain resistance. We also identified 2 long-chain fatty acids, this octadecane-dioic acid and tridecane-dioic acid. These are fatty acids that could be produced in the body, but appear to be a signal of abnormal production, as they have been previously only measured in people with Reye's disease in a study from 1986. In reality, we know very little about these chemicals. We also know that they have industrial uses and that they were reported as being used in plastics production. So these are chemicals that we have previously never been tested in pregnant people, but we found in almost all of our samples, both maternal and cord blood. And we know very little about the extent of exposure, except that they're being used in plastics production. The participants in our study came from the Chemicals in Our Bodies cohort at the University of California, San Francisco. We recruited participants from 2 hospitals, that was Mission Bay Moffitt Long and the San Francisco General Hospital. These hospitals vary in age, by race, ethnicity, and insurance status, where San Francisco General Hospital is more likely to have a diverse and higher Latina population, uninsured or not uninsured, sorry, have public health insurance and be lower income compared to Mission Bay. And Mission Bay was older and serves a larger high risk population. We have a diverse cohort, and for our outcomes, which we pulled from the medical record, we identified 57 individuals, that's 19% of our population, had gestational diabetes or were at risk for GDM, gestational diabetes. We considered those who were at risk for GDM as having failed one or more of the glucose tolerance tests they are given during pregnancy. And we had 17% who had hypertensive disorders of pregnancy. And for this, we combined both preeclampsia and pregnancy-related hypertension disorders because they're both related to hypertension and they are along a spectrum of these hypertensive-related disorders of pregnancy. So first, between the maternal and cord blood samples, since we quantified the chemicals in both, we wanted to compare the chemical levels in the maternal and the cord blood samples. And so brief orientation to this slide is that the solid dot is the median or 50th percentile, and the star is the 75th or the 95th percentile. The dotted line is the limit of detection. And in this first column, we don't have a limit of detection because branched PFAS was estimated from the measure of linear PFAS, so we couldn't have a limit of detection. Along the top is the abbreviation for the chemicals that we measured. And overall, we found that maternal samples had higher median and higher 95th percentiles of chemicals, so higher levels in the maternal samples than the cord blood samples, except for this tridecane dioic acid. All of our samples we found chemicals in all of our maternal samples and most of our cord blood samples, indicating that the chemicals can cross the placenta. We ran statistical models to calculate the odds we ran statistical models using logistic regression. We wanted to calculate the odds for the odds of the outcome for an interquartile range of exposure for each of our chemicals. These models were adjusted for maternal age, hospital of delivery, and race and ethnicity. This is a plot of the odds ratio, that's the solid dot, and the 95th percentile, that's the line for each of the chemicals. The chemicals are listed across the bottom, and the null value is the dotted line at 1. The 1 means that there was neither a higher nor lower odds of chemical exposure neither a higher or lower odds of outcome for that chemical. However, you see that the solid dot is above the dotted line for all. That indicates that we had a higher odds of gestational diabetes for all of the chemicals that we measured. And this odds range from 1.3 for branched PFAS to 1.1 for PFH-XS. And this indicates that we had, although the confidence interval was imprecise because it does cross the null value, we did find elevated odds across all of the chemicals. For hypertensive disorders of pregnancy, again, this includes preeclampsia and pregnancy-related hypertension. We found that the solid dot, again, the odds, is close to the null for most of the chemicals, except for tridecane dioic acid. So for tridecane dioic acid, we had a higher odds of hypertensive disorders of pregnancy for an interquartile range increase of exposure. Again, models were adjusted for maternal age, hospital of delivery, and race and ethnicity. So to summarize a little, this analysis builds on previous papers and non-targeted analysis methods. We incorporated quantification now into our workflow, where we were allowing us to be able to compare chemical levels across participants, and also comparing chemicals to each other. And it allowed us to also evaluate their association with adverse health outcomes. Given that chemical production is increasing and that we know very little about what these chemicals are, this adds to the literature of what we know about environmental chemicals. We were able to provide further evidence for the relationship between chemical exposures, in particular between PFAS and gestational diabetes. We were able to identify for the first time chemicals that previously had not been tested in pregnant women, these tridecane dioic acid and octadecane dioic acid, and evaluate their relationship with adverse health outcomes, showing evidence of potential link. And we also were able to identify that these chemicals can cross the placenta. There is so much more that we need to know, though, about environmental chemical exposures. So I'm going to let Tracy talk now and have some other thoughts.
All right, thank you. Excellent presentation. Just to summarize the work up to date is that, what's really amazing about the work that Jessica just presented is that we can really see the power of this technology to identify the chemical exposome, which is really identifying chemicals we have already been exposed to. So the new tools are very helpful to identify those chemicals and link them to adverse health outcomes, many of them which are both increasing and distributed unequally. But I think the other component that's important to remember is that we are using these to play catch up to things that were already chemicals that were already exposed to, and that this really points out a flaw in the way that we've structured how we manufacture and use chemicals in commerce, in that it would be better if we were, or one of our recommendations is that it would that these chemicals should be known and identified so that we know where they're being used in commerce, and that we know their potential for adverse health effects so we can prevent the exposures before we have to detect them in these biomonitoring studies. So thank you everyone for participating, and thank you, Che, for asking us to present this work, and there will be more coming. We want to thank National Institute for Environmental Health Sciences, who has been really investing in exposome work, and we have been a fortunate recipient of that effort.
Okay, thank you very much for this excellent presentation. We have some few questions coming in, and I just wanted to let you know that UNEP has just published a list of those chemicals found in plastics. It's on the UNEP website if you're interested. So they're looking at 8,000 chemicals that could be found in plastics, and they're relating them to their, of course, their CAS numbers, what kind of connections have been made between those chemicals and health outcomes, and what chemicals have been included in other UN treaties or consensual agreements of one sort. So if you'd like a list of other chemicals to look at, I'd be glad to send you the Excel file for 8,000 chemicals if you were interested. It's stunning to what we're exposed to, given microplastics or plastics itself.
Yeah.
Thanks.
Yeah, it'd be useful. It might be, I just want to say the other thing, a lot of this information, maybe this is too, is aggregated on the EPA chemical dashboard. So they keep, I don't know, I haven't checked to see if they have the UNEP list, but if they don't, they should. But that is another source of really comprehensive information. They're trying to be the most comprehensive source for chemicals and related information about them.
Okay. Yeah, that's a very useful point to make to everybody. Okay. Let's go to some questions here. We've got a few. We don't have a whole lot of time. We'll get to as many as we can. Why were no Black women included in the studies, since they have a highest rate of maternal mortality?
We did include Black women in the study. For the statistical analysis, we combined them into other. So in my summary statistics, I did not present the fully disaggregated list, but we did have, we included all the participants in our study. Our population is predominantly Latina in San Francisco, but there are some Black and Native American participants in our study. They were definitely not excluded, but like I said, I didn't disaggregate it, unfortunately, in this aspect due to lower numbers of some of the other racial and ethnic groups.
Okay, thanks. And from Ted Shetler, what does the analysis look like if you don't adjust for race and ethnicity?
Well, we thought that race ethnicity should be adjusted for, since there is evidence that there are factors that can influence both the adverse health outcomes. For example, there are higher rates of gestational diabetes among Latina populations and African American and other minoritized populations compared to others. Also, and we know that there are differences in exposure for different minoritized populations. Therefore, it met the definition of a confounder for that. I did do an unadjusted model that did not include any of the potential confounders, and we saw similar trends and similar measures of association. Really, like the intensity of the measure of association was similar across the two, and because it's an adjusted model that could potentially be more descriptive, that's why I showed that, but the results were similar still with unadjusted models.
Okay, thank you. Are there any specific occupations where pre-birth exposures dictate adverse health effects? Then of course, you should know that all the questions are coming with accompanying remarks. Say, great study, thank you very much. You should know that. But are there specific occupations that you were able to look at?
We didn't ask occupation in our study.
Well,
Tracy,
we do ask
do?
occupation, but so just like I don't want to make a comment about the study population. Again, it's we drawing from UCSF hospitals that see pregnant participants. So we have a hospital at Mission Bay, as Jessica talked about, that serves a more higher income and sometimes more at-risk pregnancies, whereas the general serves more low-income populations, and that's primarily Latinx. It's not a very large percentage of Black pregnant people coming to the general. So, that's one point about that. And then, let's see, your other question was. Oh, the occupational. So we do have some occupational, but the occupation tends to be based on what we found in the past is we actually published a study where we asked people about their occupational exposures, tended to be people who worked in cleaning industry. So, janitorial services, some a high percentage due to the, again, demographic bimodal distribution in San Francisco tended to work in a lot of office jobs. So we didn't have people who worked in factories, for example. So yeah, I mean, you raise a good point, but I can't remember what we saw in the non-targeted analysis in the occupational exposure variable. I can't remember if we had enough to really disaggregate potential exposures that are coming from, it would be primarily, it seems like, from the cleaning service component of it.
Okay. Do you have plans to continue this kind of a study using non-targeted analysis to identify other chemicals?
Yes, we just received a grant to extend the study. We're developing increasing the computational pipeline. So what I mean by that is we're going to be developing new algorithm tools to be able to better identify the features that Jessica talked about in the samples, and then also we're going to which we're going to make publicly available. We use some proprietary tools. Now we're going to use publicly available tools that have been developed due to NIH funding in metabolomics work. We're going to extend the databases. Oh, Charles, you mentioned one, but we're going to use all the chemicals that are on the EPA dashboard, which is several million. And then we have some new approaches that Dimitri has been working on to take the information that's coming out and use sort of computational toxicology tools to actually estimate the exposures based on the readings from the machine, which we haven't been able to do, but we think we can apply machine learning and artificial intelligence tools to basically develop an algorithm that people can use to estimate the exposure concentrations, which has been pretty much the biggest barrier to using this methodology. Is we have to kind of rely on yes, no, did we find it? And you can't compare levels between chemicals. And then we'll be continuing to look at the pregnancy-related complications.
How do you convey this kind of information to women in general? And what are your plans to get the information out so women might think about how to avoid exposures or to engage in possible campaigns to tighten up regulations? Do you have any how are you reaching out to the public with this info?
Well, I would say just a couple things that we do. One is we get invited to these excellent hosted webinars by Che. So that's one way. The other is we also have a component to our program that focuses on developing information for individuals about how they can avoid chemical exposures. That includes both individualized recommendations, but also how to engage in systemic change through public policy changes. Because the only way that we're going to be able to prevent these exposures, because we don't know where they are and we don't know how they're affecting our health, is really to have the government require that companies adequately inform government agencies and the public about the health harms and where chemicals are being used, and then to take them out of the supply chain for those that are harmful to health. So we do that, and then we have had some, and I think we've also collaborated with you on this, some very specific work around report back on biomonitoring studies.
Yes, okay, thank you. So I'm going to do a couple of quick questions here. Just because we have a lot more questions, we're almost out of time. Is this method possible for looking at pesticides?
Yes. Yeah,
Okay.
you can do that.
Okay. Can you talk about the potential complicating role of metabolism, chemical conversion, and non-talented screens of human samples?
So if I understand the question correctly, the challenge is that we look at chemicals that have the parent compound that's been listed in a database. And obviously these chemicals can be metabolized and turned into a different chemical. There has been some efforts to develop predictive algorithms to take parent chemicals and try and predict what the metabolites might be in the body. That's another area that we've been exploring. I think EPA has I think they have a new tool now that they're testing out to try and estimate what these metabolites are. So it's definitely an issue that is one of the areas that is for improvement in this area, in this exposomic research.
I mentioned that your research has raised many, many questions and many avenues of further exploration that will keep you busy for quite some time.
Yes, well, we'll have to prioritize them. We can't do everything, but we hope that some of you will be able to do some of it.
Absolutely. Okay, I think we're out of time now, so I'm going to once again express our enormous gratitude for the research you're doing. It's incredibly important. And thank you again for giving this presentation. I'm going to turn us back now to Rachel to make some closing remarks and talk about how further additional questions might be responded to in the future. So Rachel, I'm going to turn it back to you now.
Great. Thank you, Charles, and thank you so much, Jessica and Tracy, for this really important research and for talking with us about it today. And thanks so much for all the excellent questions from the participants. So a few quick announcements as we wrap up. A video recording will be available on Che's website soon, and so all of you will get an email with the link to that video within the next couple of days. We encourage you to support the work of any and all of the groups involved in the EDC Strategies Partnership. You'll find links to each group on Che's partnerships page. If you appreciate these webinars, please consider a tax-deductible donation to Che and/or any of these partners. We also invite you to join us for upcoming webinars. Next week on Tuesday, September 19th, we'll be presenting a webinar in partnership with Agents of Change and Environmental Justice. We'll be hearing from 3 current Agents of Change fellows about their experiences related to education to support climate justice and reflections on the United Nations Climate Change Conference of the Parties. And we'll put that link into the chat now. And then later in the month, Che Alaska will present the Not So Microplastic Problem, a conversation with journalist Matt Simon about his book on microplastic pollution. And we'll put that link into the chat as well. With that, big thanks to all of you for joining us today. We hope you found this information to be useful, and we look forward to seeing you on future webinars. Thanks again very much to our speakers and our moderator, and thanks also to Che Director Kristen Schaefer for all of her behind-the-scenes support.